Welcome everybody, and thank you for coming along to our webinar. Just going to quickly introduce your panelists. Myself, Victoria Clare, CEO of Ovacome. I'm sure I know some of you. Anna Hudson's our head of support. We've got Professor Roshan Agarwal and Mohammed, Dr. Mohammed Hussain. Both of our clinicians are from Northampton General Hospital. And what we're going to do this evening is you're going to have a presentation about ovarian cancer, essentially ascites, and how it's managed. And then a little bit about the survey that we undertook, the patient perspective, and giving patients more choice. And then at the end, we're going to offer you the opportunity to kind of come back to us with your views and to be involved in a campaign that we may potentially be launching if there's enough appetite for it. So Anna, over to you.
Thanks, Victoria. Hello, everyone. Lovely to have you with us this evening. As Victoria said, I'm the head of support, and I can see lots of familiar names joining us this evening. But for those of you who don't know me, I head up the support service with my colleagues Laura and Julia. And please do get in touch with us if you have any questions or anything you want to talk through or just want to chat. Then please do contact us. We're available by telephone, text, email, instant chat through our website, Skype or Zoom, and also there's our online forum where you can make connections with other women, and also we take part in that as well. So basically any way that you'd like to contact us, hopefully we've got a channel ready for you. So please do get in touch, and we'd really like to hear from you. This evening I'll be saying any questions that come in. Because we're recording, I won't say your name, so it will be completely confidential. So if you have any questions, if you just hover over the bottom of your screens, you'll see a chat bubble come up and a Q&A bubble. You can use either of those. Please do whichever one works best for you. And if you just drop any questions that you've got in the chat or in the Q&A, and I'll read them out at the end. So I'm delighted to welcome and hand over to Professor Roshan Agarwal and Dr. Mohammed Hussain from Northampton General Hospital NHS Trust to talk to us about managing ascites, current and future treatment options.
Good evening, everyone, and thank you for joining us this evening. I was asked by Victoria and Anna to talk to you about ascites, which is a common problem in patients with ovarian cancer. And I wanted to give you some of the work we've done over the last 10 years on this, finishing with some work that has been done with Ovacome that I think many of you have participated in. So if we go to the next slide, Victoria. So what we're going to try and cover this evening is what is ascites? How common a problem is it in patients with ovarian cancer? How do we tend to manage it? How do we look after patients across the UK with ascites? And most importantly, can we do better? Next slide. So first question, what is ascites? So in simple terms, ascites is really a buildup of fluid in the tummy. And if you look at this slide on the left-hand cartoon, you can essentially see what our inside of our abdomen or tummy should look like. And basically all our organs should be sitting there, sort of padded with some fatty tissue called the omentum. And what happens in ovarian cancer is fluid builds up in the tummy, and you can see it in the next little cartoon. And you can see that essentially there is a pool of fluid which surrounds all of our organs. And that buildup of fluid can be at quite a lot of pressure, causing the tummy to bulge outwards. And so on the right-hand side, what you see is, unfortunately, the picture of a patient whose tummy has been swollen with ascites, and there's probably around 9 to 10 liters of fluid in there that really shouldn't be there. So if we go to the next slide, we can look at how common this problem is for people with ovarian cancer. So we did a survey of all the patients that were admitted under the gynae oncology unit at Hammersmith Hospital between July and October 2009. And what we found was that a fifth of patients, and that's that sector in blue that you see right at the top, a fifth of admissions to our unit amongst patients with ovarian cancer was purely to have this acidic fluid drained. So a real significant problem. So how do we look after this? So the simplest, most effective and fastest way of dealing with this is essentially to put a little tube under local anesthetic into the tummy, into that pool of fluid, and essentially drain it out into a container. And this can be achieved quite rapidly, giving almost instant relief to people. Now, the problem is, while the cancer remains in the tummy, this fluid tends to reaccumulate quite quickly. In some people, it can be within a matter of weeks. In others, it can take a bit longer. So what people really need is some other strategy to keep the fluid under control. Now, in the old days, what we used to do was give people diuretics. Diuretics are essentially medications that make us pee a lot and dehydrate us as a way of trying to stop the fluid reaccumulating. And the ones that some people use are spironolactone and furosemide. But the downside of this is people often have a very dry mouth. It's not 100% effective, and it can cause dizziness and lightheadedness. Another drug that we tend to use is called bevacizumab. This is quite an exciting drug. It works by blocking blood vessels from growing inside cancers, and it stops the blood vessels from leaking fluid, which essentially causes this buildup of fluid in the tummy. And then the other way of controlling the fluid building up is to kill the cancer cells themselves. And here, the chemotherapy drugs that we use in ovarian cancer, like carboplatin, paclitaxel, gemcitabine, Calyx, are very effective at killing the cancer cells and then causing that fluid to be reabsorbed in some cases and stop being produced. So we'll go on to the next slide. And this essentially shows how one of these tubes looks like when it's placed into a patient's tummy. And in some people where, unfortunately, the cancer cannot be controlled, we can insert longer-term versions of these tubes. They're either called Plurex or Rocket. These are just the brand names that are used. And these can stay in the tummy under a dressing. And people then are sent home with various vacuum containers that they can attach to the drain to drain off the fluid as and when they feel their tummy is starting to get bloated. And that gives people a lot of control over managing this on their own. Sometimes people are not able to do it for themselves, and there's usually district nurse support to come in and do this for patients. So if we go on to the next slide. So this is an example of a patient that I treated recently, and this is a CT scan. So I'm just going to orientate people as to what this scan is. So the top bit of the scan is essentially the front of your tummy. The back is really your spine. And then we'll point to the first sort of blobby bit on the right-hand side. And that's the other one, Victoria. Nope, go back. That's it, perfect. So that's the liver. And then the bit next to it, that's in bright white, that's the stomach. And then the bit next to that, that's the spleen. Now, all of those three are normal, but you'll see that there is this gray area that's right around the liver. And that's the fluid that's built up in the tummy, which we call ascites. And on the right-hand side, you can see what things look like once we have drained that acidic fluid and after the patient had had 3 rounds of chemotherapy. And what it shows is all of that fluid has been drained off and has been reabsorbed. And the chemo has been quite effective in stopping that fluid from reaccumulating 3 months later. So the question is, focusing on the drainage of the ascites, how do we traditionally do it, and how could we do this better? So if we go on to the next slide. So approximately 10 years ago, when we started our work on this area, the traditional practice was to do what we call inpatient paracentesis, which means patients were admitted to come in and have this fluid drained. And at that time, there were concerns that if we took off the fluid too quickly, then it might cause people to become unwell. So the traditional approach was for people to be admitted the first day. They would then be booked in for an ultrasound scan the next day to mark a spot on their tummy for the drain to be inserted. The drains would then be inserted later in the day. And then what we would traditionally do is drain about 1 liter of fluid, then clamp the drain for a couple of hours, then unclamp it, and then keep repeating this process until all the fluid had been drained. Now, part of the problem with that was that when you clamp the fluid and the drain, it often blocks up, and therefore the drainage isn't quite as smooth as normal. The other problem is because people aren't booked in for the ultrasound prior to the admission, there are often delays in the day 2 processes of the scan and then subsequently of insertion. So the average length of stay is 3 days, but this can stretch out to even a week for essentially a simple procedure. So what we did was we did a bit of piece of research to show that if we stopped this clamping and unclamping process of the drain, that actually patients didn't feel unwell, that actually you could do it instead of in 24, 48 hours within 6 to 9 hours. And that led us to develop a process whereby we pre-arranged the ultrasound and insertion of the drain for patients. And instead of coming to the ward, the patients would go straight to the radiology department, have the drain inserted, then come to our day case unit where the drain would be left open. And generally by about 5 o'clock that day, they would have completely drained all that 9 to 10 liters of fluid. And this meant that people could essentially have a process of draining their fluid within a day without having any admissions. We found that the feedback from our patients was excellent. People really felt that this was a far better way of doing it. It gave them a lot of control over their life, and it minimized disruption to their routines. So what we then did, as with everything in the NHS, money is often an issue. So we had some people from NICE evaluate this process to look at its cost effectiveness. So if we go on to the next slide, Victoria. And what they told us was that in an average year, the NHS used up 18,000 beds for paracentesis that year. And by doing it as a day case, we would save between £500 and £1,500 per patient. And that would equate to a saving of £4 to £14 million per year for the NHS. So we were very excited about this, and we published this data in one of the national journals, expecting this to become standard of care. I was at that time working at Hammersmith Hospital at Imperial College, and there we did make it our standard of care from that year going forwards. I met Victoria a few years ago, and we thought we'd look into this a bit further. So if we go on to the next slide. And when we met, we talked about the fact that, ascites is a common problem, that we could do it safely and effectively as a day case, and that it was preferred by patients. And it was cost effective to the NHS. So what we wanted to then do is, speaking to Victoria, is really ask patients if they were receiving this day case paracentesis process nationally. And Victoria very kindly helped us with this in organizing a survey. And I'm going to hand over to my colleague, Dr. Hussain, who's going to talk you through this.
Good evening. Thank you for joining us. I'm Dr. Hussain. I'm one of the registrars that works at Northampton. Can we, next slide, please. I'm just going to talk you through the survey which Ovacome have kindly arranged for us. Following on from Professor Agarwal's talk, the main thing is we're trying to get a snapshot of exactly what the situation is at this moment compared to when Dr. Agarwal first did this study years back, and see if anything has changed. So we are trying to find out exactly what proportion of the patients had the paracentesis as a day case versus being admitted into hospital as an inpatient. And then secondly, just trying to gather patients' experiences and their thoughts on both having to come in as an inpatient and also having it done as a day case. Next slide. And as we mentioned, the method is surveys were sent out to the patients. Next slide. This is a chart just to show the breakdown of the cancers that the participants had. As you can see, the majority of the cancers were of ovarian. Next slide, please. And the distribution of where the patients were located. As you can see, we've caught most of the UK, Wales, Northern Ireland, England and Scotland. Next slide, please. So we asked the patient if they've had a paracentesis before. The majority of the patients have had it before. Next slide. And within the patients that have had the paracentesis before, we just wanted to know exactly what percentage initially had it as a day case as compared to an inpatient. As you can see, 3/4 of the patients had to be admitted to the hospital to have this procedure, whilst only 1/4 had it as a day case. Next slide, please. This is a breakdown of the patients that were admitted. It just shows that 1/3 of the patients were admitted purely for paracentesis, whilst the other 2/3 were admitted for a longer admission, and the paracentesis was a part of a more complex admission. Next slide, please. This chart just breaks down the duration of stay for the patients that were admitted for paracentesis only. And going back to Professor Agarwal's study, you can see it's mainly up to 5 days or even beyond that patients had to stay in hospital before they were discharged after having their fluid drained. Next slide. So we asked patients that have had paracentesis as an inpatient as to whether they would like to have it as a day case. As you can see, the majority of the patients were very keen to have it as a day case. Next slide, please. We can go on to the next slide. And this is, we also tried to get a feeling of what patients were thinking as far as having the paracentesis as a day case. As you can see, patient found it, this is a word bubble. Just to summarize it all, the patient found it stress-free. It was more convenient, so they can work it around their daily lives. They also found it to be safer. They found it to be quicker. Next slide, please. And finally, the results. As you can see, only 25% of the patients had a paracentesis initially as a day case. 1/3 of the patients that were admitted with ascites were for paracentesis only. Therefore, this translates that half of the patients would have been suitable for paracentesis as a day case. Based on the patient's feedback, we know that day case paracentesis is acceptable by a majority of the patients. And therefore, this we need to find a way that will allow us to have a greater accessibility and availability for patients to have this procedure done in a day case setting. Next slide. I think that's everything. Thank you.
So now we're over to me, but I just wondered whether or not, Anna, before we move on to kind of this bit where I'm essentially I'm going to kind of summarize and then do a bit of a call to action and ask whether anybody has any questions. Just to this point, do we have any questions that are kind of clinically related? And there was also one question that I just wanted to ask Professor Agarwal, and that is what percentage of ovarian cancer patients, you probably said it, but I just didn't catch it, are likely to develop ascites?
So that's a really important question, Victoria. So 1 in 3 patients with ovarian cancer will, during their journey, develop ascites. For a significant proportion, it's usually at the start of their treatment when they first present. And for a number of patients, it's towards the end when treatments have stopped being effective. So it's a significant proportion of patients who unfortunately experience this.
Okay, thank you. And so, Anna, do we have any kind of clinical questions about ascites before we sort of start to pull apart the results from the survey and obviously, you know, think about what we might want to do or what we may be able to do to improve sort of patient experience in the UK as we move forwards?
Yes, so I will come to the questions now. Can someone with ascites undergo radical surgery, i.e. scraping of peritoneum, etc.? I've heard that this does not work so well if you have ascites. Why is that, if correct? Thank you.
So people with ascites can have surgery. It's not a contraindication to surgery, but the presence of ascites essentially tends to indicate that there's a lot of studying of the peritoneum or the lining with cancer cells. And in these patients, what we often advocate is having some chemotherapy first to dry up the ascites, to kill off these small cancer cells before patients undergo surgery. I hope that answers the question.
Thank you. Were there any particular patient characteristics of those who preferred to stay in hospital? Did they live alone? Were they older, younger? Did they trust hospitals more? Any other reasons?
The majority of the patients that wanted to stay in hospital actually had a complex history of having either complications with their drains in the past. A lot of the patients were quite anxious because the amount of fluid that needed to be drained, and they thought because last time I had say 15 liters, I don't think that will be feasible within a day, and therefore they'd rather have it monitored as inpatients.
Thank you. Does early diagnosis prevent the build-up of ascites?
Early diagnosis does have the potential to avoid the buildup of ascites, but unfortunately, the buildup of ascites can be quite insidious, and so it's often difficult to pick up. But early diagnosis would absolutely help in reduce the incidence of ascites.
Thank you. Okay, so that's all the questions that we have for now, but please do drop any questions into the Q&A or the chat box. And as Victoria mentioned, we can come back to those at the end. So I'll hand back to Victoria.
Thank you. So Roshan, it was 2018 when we first had this conversation. And I was really surprised then that there had been a piece of research in 2011 that clearly indicated that it was probably, or well, that it was better for patients and that it was cheaper for the NHS and that this hadn't been adopted as a practice. And whilst Roshan said that in his experience, patients were very welcoming of being offered paracentesis a day case, and whilst as a charity, we would always advocate for patient choice, we needed to do this second piece of work that Dr. Hussain has just outlined around really understanding across the UK what's the picture. It's really hard to find out from NHS trusts actually who's doing what. It's a huge amount of work, and so obviously as an ovarian cancer support charity, we decided to approach this really from a patient perspective and kind of come to understand your experience, your concerns. Did the results of the survey reinforce what Roshan had experienced, what Dr. Agarwal had experienced, or what he'd heard from his patients? And also, in the meantime, we went and started to map where there were other hospital trusts actually undertaking paracentesis as a day case. And I think across the team, I think it's fair to say, Anna, that we were actually quite surprised at how few there were, given that the research had been published in 2011. And so really for us, the survey that we then did just reinforced that there is essentially a lack of patient choice. Now, what we would never do at Ovacome is say the procedure needs to be changed. Everybody should have this as a day case. We're not clinicians. That's not our angle. That's not our business to be campaigning for something like that. But what we would always do is we would always advocate for patient choice and for the opportunity to have their options, individuals' options explained to them. And so we're in a position now where we have a very clear set of data, a very clear patient perspective survey, a great piece of research that sort of deals with the clinical side of things and the financial side of things. So as a charity and as with our partners, so Northampton General Hospital and potentially other charities, we're looking at this and we're thinking, what can we do to change it? So I guess there are some things. Now, what we're going to do is at the end, when we finish the presentation, we're going to send out in the post email follow-up an opportunity for you to sign up to find out more about this or to move forwards with this. We will essentially hopefully be putting together a campaign piece, and we hope that some of you might join us, either to improve your choice or to improve the choice of women who don't have these choices at the moment in their NHS trusts. So we will be kind of following this up. But we've had a brainstorm, we've thought about this across the staff team, and we've thought, okay, so what can Ovacome do to help close the gap? So Dr. Hussain, what were the stats? The stats were that only a quarter of people were actually offered or given day case paracentesis, and yet what was the percentage that actually would choose it?
It was over 2/3 of the patient, over 80% of the patients would choose to have it as a day case.
Yeah. And so given that, there's clearly a piece of work for us. Thank you. Sorry, I couldn't remember the stats. Not whilst also hosting a webinar. So clearly there's a piece of work for us to do there. So what can Ovacome do to help close the gap between what patients are being offered and what patients say they'd like to be offered? So we can help by providing the resources that patients need. So that might be the support team talking through with patients how to broach this subject in their appointments with their clinicians. And I guess that's something, Anna, isn't it, that we do anyway on a daily basis, is help people understand, or feel confident to approach some of these topics or subjects around their treatment with their clinicians. We could also help you to self-advocate. So we could put together a series of resources or maybe a leaflet. We want to help you feel confident asking questions. And sometimes in order to help patients feel confident asking questions, there's really something that we need to do as a charity about providing the education, the terminology, and understanding of how, how to feel confident, when you're going to those appointments. We can also help raise awareness of the issue ourselves. So obviously we have approached other charities and organisations to bring them on board, to lend their voice to this. And to the final point there is sort of partner with other organisations to sort of really create a bit more noise, perhaps. I guess we could move this slowly forwards over the course of the next 10 years. Ideally, we would really rather not do that. Ideally, we'd like to see more choice sooner. And I guess also with the backdrop in the context of the pandemic, I think, you know, there's a real move towards trying to get people out of hospital as quickly as possible. And actually, what we've seen, certainly from a voluntary sector, from a charity sector perspective, is the NHS has become incredibly good at doing that in some areas within the pandemic. And so that whether or not there's been a change in, you know, in bureaucratic processes, or whether or not it's just that people have got quicker at doing things, or, you know, whatever it is, we've seen that actually things can change quite quickly when there's a real will. So, you know, I'm hoping that now is the time, if we're going to start making a change, that, you know, that actually we can gain some traction here. So that's what I think Ovacome can do to help close the gap. And we would welcome your views, we would welcome your support, we would welcome your constructive criticism, because what we don't want to do is set ourselves off on a course and then not have considered all of the implications. Okay. And then the last little bit is, so what can patients do to help close the gap? Well, again, this speaks to that point around talking to clinicians. So talking to your clinicians, you know, asking them whether or not this is available in your trust, asking them perhaps why it's not available in your trust if it isn't, or if it is available, you know, talking through whether or not that might be something that you might want to consider, whether or not that's something that you would like to be given the option of. Now, Anna knows, but there are loads and loads of trust feedback and comments opportunities, and loads. I mean, trusts are forever surveying patients. I'm sure you're all aware of that. And so, you know, that these are the opportunities really that we perceive that people could be feeding into their local trust and saying, you know, have you considered this? Could you do that? And also there's the taking part in patient advisory groups and involvement groups as well. So quite simply at the moment, we know that that paracentesis is not available as a day case in the majority of trusts across the UK. We know that to be the case. And if we're going to try and shift that and present that as an option to patients, then we're going to have to work together as charities, patients, and clinicians to actually start to shift that and move that forwards. So, final slide, just thank you. And any more questions? Anna, yeah. Have we got any more?
Yes, we've got plenty more. So I will make a start. Can ascites be drained from a large hernia?
Technically, yes, but we generally prefer not to drain it from the site of the hernia, because a hernia essentially contains loops of bowel in it. And so when we drain ascites, we put in a needle. And if we did it in the hernia site, there'd be a risk of putting the needle into the bowel and causing a hole in it. So we tend to drain the fluid away from the hernia. And quite often what we find is that once you've taken the pressure of the fluid out by draining it, that actually the hernia becomes smaller, because quite often the hernias are being pushed out because of this buildup of fluid in the tummy.
Thank you. I had ascites when first diagnosed. Does this mean I am more likely to have it at the end of treatment?
Yes, is the short answer. But if you had it at diagnosis and the chemo was effective, then quite often it is a case that the fluid will remain under control for as long as the cancer remains under control. But there will be a slightly higher risk of having fluid build up when the cancer comes back than somebody who never had fluid at the start.
Thank you. How can you tell the difference between weight gain and ascites?
That's a very difficult one. And a lot of people who come to see me with a diagnosis of ovarian cancer often have put the gain in weight down to simply putting on weight rather than due to ascites. And they're often very surprised that when we do take out the fluid, how much weight they've lost. So there isn't an easy way for a person at home to be able to tell the difference. But a doctor examining somebody's tummy would be able to tell the difference between weight gain and fluid buildup in the tummy.
Thank you. Further to my question about radical surgery with ascites, I thought that the point of scraping away all visible tumours was always done before chemo, so that the chemo was more successful, with reference to Professor Fotopoulou's practice. I'm therefore not clear about the answer to the previous question. Thank you.
So that's a very interesting question. So basically, in gynecological surgery for ovarian cancer, if we went back 20 years ago, we would always say, do the operation first and then give chemotherapy. Approximately 10 years ago, we did two very large studies. One was done across Europe and another was done mainly in the UK. And about 2,000 patients took part in it. And what we did in that study was we took patients who would normally have surgery and we split them into two groups. One group had surgery as normal right at the start, followed by chemotherapy for 6 cycles. And another group would have 3 lots of chemotherapy, followed by surgery, followed by the remaining 3 cycles of chemotherapy. And what that study, and the two studies were run independently, and they came to exactly the same conclusion. And what they showed was that actually doing it either way didn't actually change a patient's survival. But it did have one big advantage for patients. And that was that instead of having an operation that took 8 to 10 hours to do, if you did it right at the start, if you gave people 3 rounds of chemotherapy and then did the operation, the operating time fell to about 4 hours. And that's important because it meant the risk of death as a result of the operation and its complications went from 2% to almost 0. And patients had a much better outcome from their surgery. So at the moment, there's essentially 2 camps out there, although the majority of the surgical community have moved towards saying, actually, if something looks like there is a lot of disease and there may be a chance of not getting all the cancer out, then the right thing to do is to give chemotherapy first, followed by surgery. There is still a group of surgeons who feel that no, actually surgery should always be done up front, and there are some trials ongoing to try and address that question. But I think it is safe to say that giving chemotherapy followed by surgery is a safe and effective way and actually reduces the risk of complications for patients. And it's particularly the case for people who have fluid in their tummy and in their chest. So just like we have been talking about ascites where fluid builds up in the tummy, some people actually have fluid build up in their chest as well, and that's called a pleural effusion. And for those patients, I think there is even greater consensus that actually giving chemotherapy and taking the fluid off is the better route to go before going down the surgical route.
Thank you. Where does the ascitic fluid come from, and does this fluid contain cancer cells?
That's a very good question. So essentially what happens is, imagine that the lining of our tummy is a bit like cling film. I sometimes give the analogy of, I don't know if people are vegetarian and I don't want to offend anybody, but if anybody's ever stuffed a chicken or a turkey, and if you look inside, you'll see that there is a shiny membrane. And that shiny membrane like cling film is essentially what we call the peritoneum. And that's a cling film-like layer that covers all our innards, our liver, our spleen, etc. And essentially what happens is the cancer cell studs these, and the blood vessels grow into these little studs or nodules of cancer. Now, the blood vessels that grow into these cancer cells are slightly different from our normal cancer cells. And these blood vessels tend to be leaky. And that leak of fluid from the blood vessel is essentially what causes the ascites. Another way of thinking about it is, when we cut ourselves and then the cut heals itself, there's often a little sort of yellowish, crystally, serous-y crust that builds up where we've cut ourselves. And that serum is essentially what's making up the ascitic fluid. So when we treat the cancer and kill the cancer cells, essentially those blood vessels that were supplying that cancer cell disappear. And so the blood vessels are no longer leaky, and therefore the fluid doesn't reaccumulate. Now, as to the question of, does the fluid contain cancer cells? Absolutely. The way I got into this research was 20 years ago when I was doing my PhD. We were trying to work out a way of studying cancer cells from patients who had had chemotherapy. And we didn't want to biopsy these patients. And so what we did was we said, well, look, we're draining women with ascites and we're flushing this down the toilet. But actually, if we look at it under the microscope, they're full of thousands of cancer cells. And so to answer that question, yes, there are lots of cancer cells in it, and you might be asked to take part in some research that's going on nationally to allow people, your doctors, to collect that fluid and send it off for some labs so that we can try and work out why some people's cancer responds to chemo and it doesn't. And I would strongly encourage you to take part in those trials if you're offered them.
Thank you. Is it possible to have 6 rounds of chemo and the ascites return after 6 weeks?
Unfortunately, yes. Thankfully, for the majority of people, that's not the case. But for about 10 to 15% of people where the chemotherapy is often not as effective as we would like, the fluid can accumulate quite soon after chemotherapy is finished.
Thank you. The next question, just to let the person know who's asked it, it's a long question about NICE. I'm just going to leave out, I'm just going to change a certain detail so that it's not identifiable, and I hope that's okay. But if that's a problem in any way, then please do message me. Has it been put to NICE to try and change the pathway? Many studies are published and some trusts do things differently in many conditions. Could an optimum ovarian cancer pathway be devised of which this could be incorporated? I'm a member of the clinical expert group on a site-specific cancer that generated the national optimum pathway for that cancer, and its adoption by NHS England is leading the practical changes at different trusts to improve earlier detection and hopefully better outcomes. A multi-pronged approach by researchers, charity, medics and patients can be very powerful. The post-COVID reset and restore agenda is an opportunity to explore clinical pathways that could be made more effective, especially on the cancer priority agenda.
Can I have a go at this one? Yes, basically to all of that. However, what we probably should have said right at the very beginning is that on this webinar this evening, you're kind of hearing it here first. So because of the way we work, what we tend to do is we tend to do patient perspective work, and then we deliver that back to the patients. So really what was important to us this evening was to, so it's all very new. We've completed the survey very recently. This hasn't even been pushed out to the clinical community. We haven't sent it to any other clinicians. Nobody else has seen Dr. Hussain's presentation. So if you like, you're kind of in receipt of the information pre anybody else, even getting the chance to have a look. So yes, that definitely is what we'd like to do. I think for us, what we know from experience is the greater the number of partners that we can bring to the table, the more questions we can answer from patients and those partners and those clinicians, the more we can preempt and understand what the difficulties might be, or what the barriers might be to moving this forwards, the quicker we can probably make the change. And the other piece of work that we are yet to do, which is certainly for me a bit of a plea, if there is anybody on the call who would like to get involved, is that we know that the missing piece for us really is we've got the research, Roshan's done the financial factoring. We've now got the survey that clearly explains the patient perspective. What we haven't got yet, because we haven't gone out and sought them, is a body of case studies that bring the issues to life, that really help us to describe and explain and help people to understand what the impact is for patients. So if there is anybody who is on the webinar this evening, and certainly we will be doing a shout out across some of our other channels over the next 6 weeks, but if there is anybody who's listening to the webinar and would be prepared to share their story, then that would be very powerful for us, because it means that we can really, you know, people to respond to different, you know, things in different ways. And one of the strengths we know of working with the ovarian cancer community is we can present that very personalized perspective. That's very hard to ignore. It's very hard to ignore if you're a clinician. It's very hard to ignore if you're another charity. And I know at the point where I'm able to go with a set of case studies to some of the other charities, that they will find that a much more compelling argument than a set of statistics. Like it or don't like it, that's how it works. So there is a bit of a call to action from me, and a bit of a plea to anybody who would be interested in not just getting on board to move this forwards, but on telling their personal story. And, you know, by all means, if you follow our social media or our media or our, you know, if you receive our community news at the end of each month, you will see some requests going out. But if you want to get in touch with us in the meantime, that would really be helpful. So yes, thank you for the question. Yes, that ultimately is, I hope, where we're headed. But first of all, we need to do a lot more of the groundwork. And certainly you all on this webinar are the first to hear the results of the survey. So yeah, it's early days for us still.
Thanks, Victoria. If there was no ascites when first diagnosed, can one have ascites if there's a recurrence?
Yes, unfortunately, that's true.
Okay. Thank you. So next question. I understand that draining gets rid of fluid buildup, but in the fluid, the patient loses nutrients. Is there any way to help avoid too much weight loss slash depletion?
So that is not so much an issue for patients with ovarian cancer, because the liver is able to make up the nutrients. The real loss of nutrients that happens as a result of ascites is because the sheer volume of the fluid presses on a patient's stomach and gut such that they don't feel able to eat anything. So actually their nutrient intake is really impaired. And I remember as a registrar, when I first did a paracentesis for a patient, I remember her thanking me the next morning, and she said, "Dr. Agarwal, after you put the drain in, within an hour, I was able to have a cup of tea and a donut, and I really enjoyed it." So I think that's the real solution, is to get rid of the fluid, keep it away, and then the nutrition comes back as normal.
Thank you. What other conditions cause ascites?
So all cancers can potentially cause ascites, but ovarian cancer and pancreatic cancer are probably the two commonest, because they are cancers that are very close to the lining of the tummy, the peritoneum, and therefore they tend to cause these seedlings most commonly. But any other cancer can do this. The other condition that causes fluid buildup commonly in the tummy is liver failure and heart failure. And in liver failure, people also undergo paracentesis, where fluid is taken off the tummy. Now, it's really important not to confuse the two, because the amount of protein, and I won't get into the technical details, the way the fluid builds up in patients with liver failure is very different to patients with cancer. And therefore, in patients with liver failure, it's still important that they have slow drainage, and they often get albumin infusions. That is not necessary for cancer patients. And in fact, our historical approach to treating ascites in cancer patients came from the treatment of liver cancer patients. And that led to this start-stop approach that really slows things down and actually was at the detriment of our patients. So I think we need to think of them separately. But if you do know somebody who has liver failure and has paracentesis, for them, it continues to be the right thing to have it done slowly rather than in the way that we do it for ovarian cancer.
Thank you. Is it going forward to any cancer conference? It sounds very exciting.
It is quite exciting.
Yes, I mean, we presented it about 10 years ago when we first did that work, and it was published in an international journal. We have publicized the data. I think the challenge with publicizing these things at conferences and to the clinical community is often quite different from implementation. As Victoria mentioned, you know, this evidence to implementation gap is a very interesting thing. Now, if what we were talking about today was a drug made by a pharmaceutical company, without being cynical, I don't think we would have had this gap after 10 years, because there would have been a lot of marketing driving the implementation process. Because this was a piece of academic research without that marketing budget to roll it out and push clinicians, and there is no commercial interest here. I think it's meant that getting it adopted has been more difficult, even though it's a cost-saving thing. So I think what it'll need is exactly the sort of effort Victoria is suggesting, where the charities get together, the patients get together, clinician groups get together. And I think it needs to be top down and bottom up, where, the patients are aware and they're asking for it from their clinicians. And that puts pressure on the system. And we're also asking chief executives and MPs perhaps to say, we've heard from the patients that, your trust doesn't offer this. Why is it? Because it saves money. We have a pandemic. You'll be saving beds. Could you give us a timeline on when you would be looking to implement this? And I think, that would be the fastest way of narrowing the gap, rather than waiting till 2030 and perhaps having not a dissimilar survey again.
Which we don't want to do.
We don't want to do.
So yeah, top down and bottom up. And I just know from experience how incredibly powerful the voice of a group of ovarian cancer patients can be. And I also know from experience, because we listen to our members a lot before we implement new services, that actually we've got a really vocal group of people who talk an awful lot of common sense. And I think if we can harness that, and we can pull in some other organizations to really get on board and lend their support, and we can do the top down bit as well, then yeah, as Roshan said, I think we can pick up a pace really.
Thank you, Victoria. Just to say, we've had a few more questions come in. We are in the last 5 minutes, so I will ask the questions that have come in so far. But if anyone has any further questions, please email support@ovacome.org.uk, and I've put that email in the chat, and then we'll come back to you. Next question: are all ascites due to ovarian cancer containing cancer cells?
The majority of acidic fluid does have cancer cells. So about 90% of people will have sufficient cancer cells for that to be visible under the microscope.
When the ascites return 6 weeks after chemo finishes, what options are available?
So we would go through the same options as I highlighted in the slide. So what we would first do is drain the fluid, and then we would look at what drug options there were to try and control the underlying cancer.
Is palliative chemotherapy the only option for older patients with ovarian cancer and ascites? Could a better system of paracentesis control symptoms?
That's a very good question. So sometimes the drugs are not good enough at controlling the fluid. And that's why about 10, 15 years ago, the idea that instead of coming in repeatedly for having the fluid drained in hospital, could we leave the drains in the patient's tummy came in. Now, the problem with our standard drains is if we left them in, they would get infected. So 2 companies called Plurex and Rocket developed these catheters that actually could be left in long term. So for some patients, older patients who are frail, who don't really fancy chemotherapy, and who have ascites, what we do is we put in these long-term drains, and then they have full control over when they want to drain it without having to come to a doctor or come to a hospital. And they can do it in the comfort of their own home. And if they don't want to do it themselves, then a district nurse can come to their home and do it for them. And that, in some people, they do it 2 or 3 times a day to keep their tummy nice and flat without ever developing a bulge.
Thank you. Is this information about ascites and its treatment available on the Ovacome website?
It will be very soon. We just need to produce a policy paper, essentially, for that. And in the meantime, we've approached some other charities to get on board and see if they will lend their voice to it at this stage. For those of you who are on this, who are on the webinar, and for anybody else that's interested that's listening back to this, you can always get in touch with us and we can send the information through as soon as we post it. I guess one of the purposes of this webinar was to see whether or not we had the support of, or whether or not it seemed like a sensible, next steps progression. And I guess from your feedback, it really does look like that. So thank you for your positivity. And yes, you will be seeing it on our website soon.
Thanks, Victoria. So we are down to our last 2 minutes. We've not got through all the questions, but I have made a note of the ones that we've not got to, and we will follow up with you about those questions. So thank you for submitting those. We've had a few comments from people saying, thank you, all really enjoyed this and learned a lot, and someone else saying really interesting and learned a lot. Thank you. So thank you very much, everyone. And then just a question to finish, because it's quite a helpful summary point, really. Are patients offered the choice of having drainage as an inpatient or day patient?
Not often, I think, or not everywhere, I think, is the answer to that. Professor Agarwal, do you want to add to that?
Yeah, no, I think that was really the point of the study we did and of the survey we conducted, is really to ask how often patients are getting that choice. And I think what the survey is showing is that only a quarter of patients nationally are getting that choice. And actually, if we take a very conservative estimate, at least half the patients could have been treated as a day case. And that means there's a lot of hospitals out there that just haven't implemented the day case process. When we published our paper, as a supplementary, we uploaded onto the web all the process documents that we developed in order to allow people to implement it at their hospital. So if any hospital ever wanted to do it, they would just have to look at our paper, download all the bureaucratic paperwork they would need to do it, and get on and do it the next day. So I think, that's really what we were hoping through this webinar and through this survey to establish, was how big a gap is there? Because really, from a practical perspective, there really isn't a lot that needs to be done, because the technology to do it exists in every single NHS trust in the country. It's really about generating the willingness to implement a pathway for each hospital to say, yes, we will use the resources we already have to do this.
Thank you very much. So we've come to the end of our time, everyone. Thank you very much for joining us this evening. Just to let Professor Agarwal and Dr. Hussain know, we've had some more comments come in, people saying thank you, it's very informative. It's really interesting. Someone's happy to tell their story, and someone's saying that they didn't realise how lucky they were to get treated as a day case at their local hospital recently. So thank you very much.
Thank you.
Thank you.
Thank you.